Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week it's a conversation about lung cancer with Dr. Lynn Tanoue. Dr. Tanoue is a professor of medicine in the section of Pulmonary, Critical Care, and Sleep Medicine at Yale. Here's Dr. Weiner.
Could you just tell us a little bit about yourself and how is it that you got interested in lung diseases, and then perhaps even more relevant, how you became interested in early detection of lung cancer?
I decided to go into pulmonary medicine really because it was like super internal medicine. The lungs interact with every other organ in the body, and I found that really fascinating. I also have a personal story, two stories relating to pulmonary. My dad, who was a really talented surgeon, actually had horrible tuberculosis that he contracted when he was training in Chicago. And so that for many years, I led the tuberculosis clinic here at Yale, and I still have a deep interest in that. And the interest in lung cancer actually really relates to him also, because he developed lung cancer in his 80s, actually. So he'd had a long and really wonderful career. But watching him work his way through our very complicated healthcare systems at a time when he was struggling with diagnosis and complications and so forth. He was also in Honolulu, my home state, and so trying to help him navigate care from a distance really pointed out to me how complicated the care was and still is. And the first foray then into thoracic oncology more than 20 years ago for me really had to do with trying to help my own patients navigate their journeys with lung cancer in a way that was more patient-centered and supportive of their needs, as well as providing them access to state-of-the-art, cutting-edge lung cancer care here at Yale.
Yeah, I mean, it's so important, and it's worth pointing out that your father, in spite of being a doctor, still had trouble accessing the healthcare system, which I think that many of us find, and it just leaves us feeling that for those who don't have connections and don't have knowledge, how much even more difficult it is.
That is the goal of our thoracic oncology program, is to provide that navigation through these complicated systems. And they're complicated for a reason. If you're trying to deliver best care, it requires the input of many different people. And keeping that all coordinated is obviously one of our major goals.
Yeah, no, absolutely. So can you tell us just how common lung cancer is? It is the cancer that takes more lives than any other. And although it's been going down in incidence in recent years, it's still a pretty common cancer.
It is really common. It is the second most common cancer diagnosis besides, benign tumors of the skin in both men and women, second to breast in women and second to prostate in men. It causes more deaths than those other cancers. In the world, it is rising. In the United States and in some countries in Western Europe, as smoking has decreased, we've seen declines in how many patients are diagnosed. But in the world, 2 million people on average are dying of lung cancer every year. And that number is rising.
And that is obviously a huge number. Could you speak for a minute about what happens with lung cancer risk when you stop smoking? And while it's certainly the very best thing for people to stop smoking, I think sometimes they're a little discouraged that their lung cancer risk doesn't go to zero.
Well, it does start declining reasonably immediately. Every day, month, year that you are further away from your last cigarette, the lower your risk should be. There are so many benefits other than decrease in lung cancer
Absolutely.
that I think let's remember that vascular benefit also begins very quickly after you stop smoking. If you keep smoking into your 70s, your risk of lung cancer is about 1 in 6. And so you really don't want to get to levels that high. The younger you are when you quit smoking, the better, but certainly even quitting into the 6th decade of life, the 7th decade of life confers benefit.
Well, I don't think there's any question that for all the health benefits, we want to encourage absolutely everyone to A, not start smoking, and B, if they do, to stop as soon as possible.
Absolutely.
Unfortunately, smoking rates have gone down, and in the U.S. at this point, what's the rate of people smoking?
So about 14% of adult Americans are committed smokers, meaning they smoke every day. We are seeing this concerning rise in adolescents in vaping, electronic cigarettes, and cigarettes combined in our youth those rates are higher when you combine them than they used to be for cigarettes alone. And we really can't know the health effects of vaping. We won't know that for decades in terms of whether there is risk to the lungs, including cancer.
So, turning more to some treatment issues, people develop sometimes lung nodules. You're the director of the lung screening and nodule program. Can you just tell us a little bit about lung nodules and why they develop and what we do about them?
Sure. So a nodule is basically a spot. And if I see something on a chest x-ray or a CT scan of the chest that isn't lung and that I can draw a circle around it, so it's reasonably well circumscribed, we call that a nodule. We call them nodules, these spots, until they're about 3 centimeters. And then after that, they're big enough that we call them masses. So lung nodules are really common. We're seeing them more and more because imaging, including chest x-rays and CT scans, are just so widely available and used for so many purposes. And the current estimate is that there are about 1.5 to 1.6 million lung nodules identified in the country each year. And that's mostly not from lung cancer screening. It's just from everyday imaging. Fortunately, the vast majority of those lung nodules are not lung cancers. But I think that's a very scary thing to see on your X-ray report or to be told in the office by your healthcare provider. And so it's really important to know that not all those nodules, and most of them, are not malignant. They may signify some other disease, but most of them are small enough that they don't require further intervention, although sometimes they need to be monitored.
And what makes a lung nodule one that would make you want to intervene or perform a biopsy in particular, or a needle aspiration? So
the bigger the nodule is, unfortunately, the more likely it is a cancer. However, infections and inflammation and even scars can cause nodules that sometimes are quite sizable. And so the appearance of the nodule, the spot on the imaging study, typically a chest CT scan, usually is our guide. Some nodules look to specialists like radiologists, pulmonologists, thoracic surgeons, like they're likely inflammatory or infections. And so the process of evaluating them might really be treatment empirically and monitoring. Things that look much more worrisome because they're larger or because the individual has a lot of lung cancer risk factors might trigger a more immediate intervention like a biopsy or even a surgery. But even in those cases, we often will do a short term, meaning a few weeks to up to 3 months period of waiting to let that spot declare itself, because in many cases it will declare itself as not needing an intervention because it shrinks.
And then, of course, every once in a while, someone's had a CT scan 3 years earlier or 5 years earlier, and you can show that that nodule was there and looks exactly the same as it did 5 years ago, which further reassures you that it's not anything to worry about.
Absolutely, and that's a really good point, that looking for those old imaging studies is something that is done or should be done routinely. Unfortunately, not all our healthcare systems talk to each other, but generally with enough due diligence, if we know that there's been imaging done here or at another institution or even across the country, we can retrieve the images and do that comparison, because that comparative information is incredibly useful.
And before we talk about lung cancer screening, can you just talk a little bit about how lung cancer is usually diagnosed?
So in 2024, still, most people are diagnosed because they have symptoms. They come for evaluation because they have persistent cough, or they're coughing up blood, or they have unexplained chest pain, or they have unexplained shortness of breath. Symptomatic disease like that generally indicates there's something really wrong in the chest. And those people who have those kinds of symptoms typically come to medical attention because they get a chest X-ray and then often a chest CT scan. People who are diagnosed with early stage disease typically don't have symptoms because all they've got is a nodule. And as long as that nodule is not touching something important in the lung that might cause symptoms because of that. And the lung is a really big organ, so you can hide nodules pretty easily. Those are generally discovered incidentally, meaning there was a scan done for another reason. So for instance, lots of people now have coronary calcium scoring studies, which are also chest CT scans, and we see a big portion of the lung on those scans. So even if the purpose was not to look at the lungs, we kind of get this free look, and we might find nodules that way. Or the scan was done like in the emergency room because you tripped and fell and hurt your chest or something like that. So we don't want to find these things by serendipity because we don't find them early often enough, and that's what screening is meant to change.
And again, before we get to screening, of the people who have symptoms, how many of them at the time of their initial presentation have cancer that's already spread outside of the lung?
Unfortunately, many of them do, because although the symptoms may still be in the lung, by the time you have symptoms, typically the cancer has had time to grow. And if you have time to grow, the cancer has had time to spread.
Well, I think all of this points to the potential importance of screening, of finding cancers very, very early. And we're going to talk more about that when we come back in just a minute and hear about new approaches for screening for lung cancer, and also talk about who should be considering this and who perhaps shouldn't be. So we'll be back in just a minute.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications, as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner. I'm the Yale Cancer Center Director, and I'm here with Yale Cancer Answers. My guest this evening is Dr. Lynn Tanoue, who is the director of the Yale lung screening program and nodule program, whose interest is in early detection of lung cancer, among other things. And we're going to move on now and actually talk about early detection. So early detection for lung cancer isn't something we thought about 30 years ago. It's more recent than that. Tell us a little bit about the studies that made early detection something that we can consider when we see patients in the clinic.
We may not have had screening 30 years ago, but we were desperate to have screening because 30 years ago, lung cancer was really on the rise. And while it's declining now, we could really save a lot of lives if we screened everybody who's eligible. So the turning point really relates to predominantly in the U.S. one study, which was called the National Lung Screening Trial, the NLST. And the NLST proved essentially that more lives could be saved if lung cancer screening were performed with low radiation dose chest CT in people with high risk for lung cancer. And by high risk, that eventually ended up meaning about 2.5% risk of lung cancer over the course of 6 years. So that the entry into the National Lung Screening Trial, if you were an individual who wanted to participate, and that study recruited volunteers very, very quickly. Over 50,000 people participated in this study. And to be eligible to participate in that clinical trial, you had to be age 50 to 80 and have smoked 30 pack years. You had to be currently smoking or have quit within the past 15 years. So a pack year is the equivalent of smoking a pack a day for 1 year. And, we do the math all the time, depending on what somebody tells us their smoking intensity was. And so that study really basically proved that screening works. And so individuals who were screened annually with low dose, and we're talking about very low radiation dose CT scan, had less deaths than their comparison population, which were individuals who were screened annually with a chest X-ray. And there was another study that published its data around the same time, and that was the prostate, lung, colon, ovarian screening trial. And in that study, the comparison for lung cancer screening was annual chest X-ray versus no screening, which was actually state of the art then. And there was no difference in the number of lives saved by screening with chest X-ray versus no screening. And so that the National Lung Screening Trial was published in 2011. And 2 years later, the United States Preventive Services Task Force, which is the volunteer body that advises the Centers for Medicare and Medicaid Services, recommended that screening be done in a population of Americans that basically were the same as the people who had participated in the National Lung Screening Trial. So that was the 2013 recommendation. Medicare approved this in 2015, and we were hoping that screening would take off, but it's been slow because preventive measures aren't super exciting, and so they don't get as much press, I don't think. And awareness by both healthcare people and patients was low and still could be improved. And recognizing after several years that those eligibility criteria based on age and smoking intensity actually were screening fewer women and fewer minorities, particularly African Americans. The eligibility criteria for screening were expanded in 2021. And right now, if you are ages 50 to 80 and you've smoked 20 pack years and have quit within the past 15 years or are still smoking, you are eligible for screening. And that applies to about 14 to 15 million adult Americans.
You know, when you first described that large study done using low-dose CT scans, I wondered why they were doing a chest X-ray in the other arm, given the fact that I had never thought that they were terribly useful. But I suppose it was a fancy placebo in some ways, since, in fact, chest X-rays themselves are inadequate. So with this kind of screening, what are the kinds of pickup rates that you see? In fact, are you able to pick up a couple of % of people who have lung cancer?
So I'm glad you asked about nodules, because if you are eligible for lung cancer screening with low-dose CT, unfortunately, it's likely you'll have nodules. And in fact, about 20% of people will have a new nodule annually on their screening study, but 96% of them are not worrisome. And so that's one thing to remember if you're going to have a lung cancer screening study, that if you have a nodule, don't panic, because more likely than not, it's not a cancer. And so I think I already said that about 2.5% of people in the National Lung Screening Trial got lung cancer over the span of the 6 years of follow-up of the study. That's probably an underestimate of the percent of people we see in real practice doing screening. And that relates to the fact that people who participate in clinical trials tend to be healthier than the general population. And so the early results of community academic medical center, across the country, real life practice after the National Lung Screening Trial data were published and Congress essentially approved lung cancer screening, is that the rates are actually a little higher. Still, maybe 1 to 2% of screens per year show a cancer, but no more than that. And that may seem low, except when you think about 14 to 15 million Americans are eligible, that's a lot of people who could be detected early.
Well, it's still a lot. And, in truth, having a CT scan isn't a terribly uncomfortable procedure. It's pretty easy if someone just gets into the mindset. And unlike some other screening procedures, which are associated with more discomfort, this is one that, you walk in, you lie down, you get your scan, and you're done.
I'm so glad you brought that up because we talk to patients. There's a requirement to have a discussion called a decision support discussion prior to your first screen, not afterward, but the first one. And it is to discuss these sorts of things because I think there is a misconception that a CT scan means you're going to go in a closed box. And the reality is exactly what you said. You walk in, you usually don't have to undress. You lie down, you zip through the donut-shaped scanner, which is not closed, in about one breath, and you're done. And so it definitely takes you longer to park your car than it does to get the scan. There's no needles. Really, it's completely not uncomfortable, and it's very quick.
Well, I don't want anyone to think that I'm arguing against breast cancer or colon cancer screening. But by comparison, this is actually easier because I can't tell you how many patients I've taken care of over the years who have complained about mammograms, and yet most women still get them on a regular basis. And no question that colonoscopies are not the most pleasant thing, and a fairly sizable proportion of our population gets those. But so how many people actually get lung cancer screening? I think this is going to surprise people.
Right. So not enough. And
Right.
The American Cancer Society just published state data, and Connecticut does pretty well compared to the country, and we are screening about 5% of eligible individuals. That is actually using the American Cancer Society recommendations for who should be screened, which are more liberal than the ones that are followed by Medicare. But even if you are really generous and use the most stringent eligibility criteria, we're still only at about 12, 14%. And so screening for lung cancer is a long way to go. And I'm really glad we're having this talk because I hope whoever is listening will talk to whoever they know who might need lung cancer screening and encourage them to go.
If you are a person who is between the ages of 50 and 80 and has smoked the equivalent of 20 pack years, or 1 pack a day for a year times 20, and you either stopped in the last 15 years or are still smoking, you're eligible, correct?
That is
got that.
absolutely.
I got it. I've got it down to memory now.
Yeah, absolutely correct.
And, this is something that saves lives.
Absolutely. Absolutely. And the test is painless and quick. As a woman, I know what it feels like to have a mammogram. This is nothing like that. Eric, you are the breast cancer expert, but I believe that in excess of 75% of women who qualify for mammogram get mammography for screening, and we really need to push the lung cancer screening rates up there.
No, and we know the population of people who need it the most. And you and I have both said this, but this saves lives. And beyond that, sometimes people don't do tests because they're terrified of them. But most of the time, someone is going to just get a clean bill of health after this.
Absolutely. And then you can walk away and feel really good about it.
And the interval at which one is supposed to have these is annually?
Annually. Mm-hmm.
Yeah, well, this certainly makes a great deal of sense. So what's being done to encourage more screening?
I think this is an issue with awareness. And again, I'm glad we're having this discussion. Most people don't know that lung cancer screening exists and don't know that they're eligible. And I think in the everyday busy practice of our primary care providers, this still hasn't hit the radar in a big way. And so awareness is something we're really trying to work on. And that means going to the patient too, not just depending on their interaction with their healthcare providers. You can ask to have lung cancer screening.
So it sounds like our public health measures should both be about reaching out to the community, to the patients, and also educating doctors and advanced providers, nurse practitioners and PAs who are taking care of many of our primary care patients these days.
Yes, and we really try to do that. Again, everybody's busy, but this is really important because lung cancer screening will save a lot of lives.
And just to reinforce, people shouldn't think they can get lung cancer screening and continue to smoke. They still need to stop smoking. And that's probably first and foremost, but they should also get screening.
Absolutely. Quitting smoking has so many health benefits. I think a person who's motivated enough to go get lung cancer screening can quit. And I would encourage them to think about it as you have that discussion about screening.
Dr. Lynn Tanoue is a professor of medicine in the section of Pulmonary, Critical Care, and Sleep Medicine at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.